So any questions on stuff we covered last time? Start up the ortho stuff, some pain management things. Okay, so we talked about NSAIDs, we talked about acetaminophen, now we get into the opioids. So we'll cover some of the more common ones you're going to run into. I'll talk about, whether they're oral or IV options, but just know that I'm not going to test on that specifically, but just be kind of familiar with where you might see these being used, how you might see them being used, because these are pretty common medications. First one's going to be codeine. I'm sure most people have heard of codeine before, right? This is usually found with acetaminophen. It's called Tylenol number 3 when you see it like that. It usually has 30 milligrams of codeine plus 300 milligrams of acetaminophen. I guess Tylenol 1 and 2 didn't work too well. Tylenol 3, those seem to be just the right spot. Who knows? Now, some people don't do really well with this medication because codeine itself isn't a great analgesic. It has to be converted over to morphine. And again, it's kind of makes sense based on they're all kind of coming from the original poppy plant, if you guys remember. Codeine, morphine, heroin are all kind of like found kind of within that same kind of chemical family, essentially. But you have to have a CYP2D6 enzyme to convert codeine to morphine. The more CYP2D6 you have, the more you convert that over to morphine. What do you think about the efficacy of that drug at that point? Better or worse? Should be better. More morphine, more fine, right? Means you're getting more analgesia from that. However, people have low amounts of CYP2D6 will have a low amount of that being converted over. So some people don't do very well with this, and that makes sense because if they don't convert a lot to morphine, they don't get a whole lot of analgesic effect. And actually, we see some people have these polymorphisms, or some will have more than others. We're actually having there's a black box warning on this now because we're having cases of kids who were going in, they're getting tonsillectomies done. They had obstructive sleep apnea, and then after surgery, what usually happens to kind of the local area? Swells up, right? So you have these kids who had kind of obstructive sleep issues to begin with. You have the swelling, and one of the big side effects you run into with opioids, anyone know? Respiratory depression, right? So these kids, some of them who had a lot of CYP2D6 were converting a ton of this stuff over to morphine. They were having sleep respiratory depression associated with this obstruction. They died, right? So again, very dangerous, and so we've actually taken it off our formulary at Nemours. We don't use it anymore. In a lot of cases, pediatrics will not use codeine anymore. However, still may use it as used occasionally. Usually it'll be a C3, so it's going to be kind of in the wimpier sort of category versus a lot of the other opioids we're going to be looking at here going forward. Yes.
There's so many interactions to worry about. Is there a way to find out what kind of enzyme activity a person has? Is it just not simple enough that we don't do it?
It's something where it's pretty cost intensive right now for a lot of these things where
How do you like what would need it?
yeah, so some things are going to be are going to be done often enough where there are commercially available methods to do that. So for instance, with certain polymorphisms for warfarin metabolism, because warfarin for a long time, that's all we really had for kind of long-term anticoagulation from an oral standpoint. We had so many people that were on warfarin, like we needed some way to determine if they had any kind of polymorphisms that affected how their body's going to handle that. And so that one is commercially available. It's not done super frequently, especially nowadays. You have newer oral anticoagulants that kind of circumvent using warfarin in some cases. However, with this one, if the risk is there for codeine to be converted over to morphine, it can differ between patient to patient. I don't have a good commercially available test. The best thing to do is just to avoid it altogether. You're going to see we have a ton of options for opioids from an oral standpoint, from an IV standpoint. Like codeine, you really don't even need it in the first place. And again, some of those people are just not going to respond well to it because of those issues. And so it's like, just screw it. We don't even need it. We have other drugs we can use instead, right? You would, if you were going to do the test, yeah, basically you would draw some serum. You would spin it down and see what their expression was for that CYP2D6 enzyme. So you can kind of classify them as a slow metabolizer, regular metabolizer, or fast metabolizer. A lot of it goes back to the genotype for the patient. So they see 2 copies of a particular version of that gene, they'll say, okay, you're an ultra rapid metabolizer. There's one we do pretty commonly. If you remember back when we talked about TB medication, remember isoniazid? Remember, there's another one, like hydralazine, I should say. It's another very common lookalike sound-alike medication, but hydralazine. That one is when you may be at risk for having anaphylactic reactions to if you have a certain HLA gene present. And so that's another test we'll do somewhat commonly for some of these medications, because if it's a drug you have to use because there's not really any good alternatives, you want to know that person's at high risk for having anaphylaxis. So there's some cases where we use tests for pharmacogenomics, but in a lot of cases, you kind of give the drug to the patient, see how they respond, and then potentially change it or use something else. But in these cases, because that risk for especially that risk high risk patient population where they're having a lot of swelling in the first place, like it was just too big a deal, and we're just avoid it. We have other drugs we can use. So again, codeine gets turned into morphine. Morphine is a very common one. We have lots of good oral options. We have IV options available. If you go into the ER complaining of pain severe enough, you'll probably get some IV morphine for most people. There's immediate release preparations, extended release preparations. So if you see someone who's on 2 forms of morphine, that may be clinically appropriate, right? Because they'll be on one for extended release for kind of chronic control of their basal pain, and then they'll be on immediate release for what? What was that term we talked about? Those little spikes in pain? Breakthrough pain, right? So that's why you'll see that. You may see like morphine. You see MS Contin is the usual brand name for the extended release preparation. You may see them on that, say Q12 hours, right? Scheduled every 12 hours versus the breakthrough, the immediate release morphine will be say Q4 to 6 hours PRN breakthrough pain, right? So you need to make sure that the indications are written correctly for that sort of thing. Speaking of prescriptions, I'm very close to having all your guys' done, so that those grades should be in pretty soon, so you can check them on your spring break and say, woo. Got a good grade, right? Anyway, right. So just be aware that some people, especially elderly patients, have issues with some of these drugs, especially if their organ function is starting to go downhill, and they will start to accumulate metabolites. Okay. So for instance, we see this morphine 6-glucuronide that some older patients will start to accumulate, especially if they have hepatic dysfunction or renal dysfunction. When this happens, they actually find greater analgesic properties from this, which sounds like a good thing. However, because it has more analgesic properties, what else do you think it might do? More side effects, right? So you can see more respiratory depression associated with that. So again, typically for older patients, you want to shoot for things that don't have any active metabolites. You want to shoot for things that are very water soluble, so they can be eliminated through the kidneys as easily as you can. That's usually what you kind of shoot for. The other big thing to watch out with morphine is that you're going to see significant histamine release. What do you think can happen due to histamine release? A lot of itching. It won't really be anaphylaxis necessarily, but you'll see a lot of itching, you'll see rash, you'll see they'll potentially some nausea, vomiting associated with it. Some people do really poorly with morphine. They'll get it and they're just like, oh, I just feel like crap, and they get really itchy and all that. We can treat that by giving some antihistamines. But again, looking back at some of our antihistamines, like what are some good examples? Benadryl is a big one, right? So what's a big side effect of Benadryl? Drowsiness. What's a big side effect of opioids? Drowsiness, right? So again, you can kind of see some issues with that. You don't necessarily want to cause increased drowsiness due to that. Otherwise, your patient will be passed out, and you may not want that to be the case, right? So we have other drugs we can use instead to kind of get around this. So hydrocodone, I'm sure most people are familiar with hydrocodone, at least have heard of it before, correct? Lortab, Norco, you've probably heard of this before. Rarely we find it alone. It's usually mixed in with what other drug? Yeah, acetaminophen is the most common one. So rarely found alone. Actually, there's a newer product called Zohydro ER that has it's just extended release hydrocodone by itself, and I've seen dosage forms up to like 80 milligrams, which normal dose of hydrocodone can range anywhere between like 5, 7.5, 10. This stuff up to 80 milligrams. It's a huge amount of hydrocodone. And one of the problems with these extended release preparations is that some people who are abusing these drugs for abuse purposes will try to break that extended release preparation. They'll try to crush it, or they'll do something to try to isolate the drug out, because now all of a sudden you have 80 milligrams of drug all at one time. See a lot with the extended release oxycodones, and it's a big problem for abuse. But anywho, you will see this one does have some conversion over hydromorphone, so there is some concern about that CYP2D6 polymorphism, but not nearly to the same degree you'll see with codeine, right? There's not been any deaths that we know of that's been reported due to this. However, you may find some people respond really well to hydrocodone. Maybe they have a lot of CYP2D6 to make hydromorphone, which is Dilaudid. We'll talk about that in a second. Or they may have very low amounts of it, and they may not be able to metabolize as quickly, and they don't really get as much of effect. Just know that less clinically significant than the codeine example, but something you may be concerned for. And very frequently, this is the #1 prescribed medication in the U.S. Why do you think that is? Okay, it works well. It's a good analgesic. Show up to the ER, you got pain. Guess what you're probably going to go home with? Script for Lortab, right? So it's a very, very commonly, it may not be the biggest money maker because there's a lot of generic formulations that are out there, but if you look at the top 100 drug list, oftentimes this is towards the top. Now, it used to be even further ahead of the game because of the fact that it was a C3 for a long time. It used to be Schedule 3 substance, which if you remember back to how we write prescriptions for those, how many refills can you do for like a C3? You can. C3 through 5. can do up to 6 months worth. So you can do 5 refills on his prescription. So if you have a patient with chronic pain issues, this could be a good thing. However, you'd have a lot of these pill mills are writing fraudulent prescriptions for huge amounts of hydrocodone. Now it's a Schedule II substance, which means you get no refills on that, and it's much more strictly regulated. So because of that, they're trying to curtail a lot of that abuse associated with these drugs, and now it's a C2. But it's still one of the most highly prescribed because most people are very comfortable with it. They use it very frequently for these acute sort of pain issues. Just so you know, as far as like liquid formulations, if you ever go to work in pediatrics and you need a liquid preparation because oftentimes they can't take tablets, hydrocodone does come in a liquid form that is compounded with acetaminophen. It's called high set liquid. We use this stuff like water basically because especially on Fridays when we have a lot of these kids coming out of the ENT and the OR and they're getting, they're all post-op and they're getting their scripts for the weekend for pain control. It's usually high set liquid. So we go through this stuff quite frequently. The other problem is that if you have, a lot of places don't carry high set liquid because of the fact that it's kind of a niche object, right? A lot of kids don't necessarily need hydrocodone, right? So we'll have these parents that would come out, the kids get out of surgery, and they say, okay, well, you got to go find this stuff. They'll call around to the pharmacies. And if you call a pharmacy and ask them, do you have hydrocodone liquid? What do you think they're going to say? They're say no. Why? They're worried about attracting drug seekers. What's the other thing that drug seekers might do? Why try to rob them, right? So if you ever go and you call, hey, do you have oxycodone in? Do you have OxyContin 80s? And you're gonna hear, no, we're out of stock, right? And that's just a blanket thing you'll hear with all pharmacies. And so you have these parents who have legitimate pain concerns for their children who can't find this stuff. And even if they call, they're never gonna get a straight answer. And then if you go to a pharmacy, you have to see if they don't have it, and then it's going to take 24 hours for them to get it in. If your kid's crying in the car because they're hurting, that's kind of a big deal, right? So again, this is why we do things like, we had an agreement set up with the local Publix, so it was near our hospital, to say, okay, can you please carry this stuff? We will send patients to you to make sure that they have it, and that was a good arrangement we had for some time. But just know that can be a difficulty for patients, and finding this stuff can be a hardship sometimes. Anywho. Next, you have oxycodone, which is found either by itself, either roxicodone, the immediate release. You have OxyContin, which is the extended release preparation, the one that's huge for abuse purposes for a long time. And it will also be compounded with acetaminophen. Anyone know the brand name for that? That's Percocet. So anytime you see that CET on the end there, that's usually kind of referring back to the acetaminophen content. But so Percocet's a very common one as well. This one does have another CYP2D6 issue, but again, very clinically unimportant, but just know some patients may respond better to it than others. Typically with hydrocodone and oxycodone, you see a lot less histamine release associated with than morphine. Morphine is really the big one for that. So again, if you had a patient who said, oh, I can't really get morphine, I get really itchy, this is a good agent to switch over and try. You can try oxycodone, you can try hydrocodone. These only have oral options that are available for them. We'll talk about some IV options that you could switch to if IV morphine was not an option for these patients. Okay, so that first one here is going to be Hydromorphone or Dilaudid. This one is a very good analgesic, and you'll find that there's different potencies between these agents. So for instance, 5 milligrams of hydrocodone may be equal to something like, say, half a milligram of Dilaudid, which may be equal to, say, 50 micrograms of fentanyl. It's important to make sure you keep these in mind, because if you screw it up and say, hey, I want to give my patient 2 milligrams of fentanyl, you're going to kill them, right? Or if you say, I want to give 10 micrograms of morphine to my patient, they're going to laugh at you and say, like, well, I'm still in pain. You're not really helping my situation at all. Important to keep that in mind, because otherwise, if you goof this up, you can potentially kill somebody, right? This stuff is very dangerous in the wrong hands. But you guys won't do that, right? You guys will be perfect prescribers, I'm sure. Anywho, Hydromorphone or Dilaudid is very good. Dilaudid, I've heard a few patients call that, so if you're here, that's... It will have a shorter half-life than morphine, so it's good for kind of short, really acute sort of pain issues. So we see this used a lot, especially in kids who are immediately post-op. If they're in the PACU, kind of recovering, they're having some pain issues, we'll give them, Dilaudid will have orders for, like, say, Q5 minutes, PRN pain for 3 doses. And that way kids can get up to 3 doses, and they can get very kind of rapid response to their pain issues, right? A lot less histamine release with this, and this is a good IV option. There's some oral formulations available. This one's a good IV agent that you could switch to if morphine really wasn't a good option for you. So, and again, when you think about it, like a patient has myocardial infarction, what's one of the drugs you give them immediately? They're having chest pain. You give them what? Nitroglycerin. What else? Aspirin. What else? Ramona is your Morphine, you give them morphine, right? They always say you give them morphine. There's nothing magical about morphine. You can switch over to use another opioid if you needed to. We'll talk about allergies in a second, but just know that there's kind of 3 classifications of opioids. There's your naturally occurring opioids, which is like your morphine, your heroin, your codeine. There's semi-synthetic opioids, which look similar to morphine, but not quite, right? They look different enough, and that's important because when you're looking at allergies, there can be some cross-reactivity there. Again, it depends on what specific portion of the molecule your patient is having antibodies against. There could be some chance for cross-reactivity. Final group we'll talk about in a few minutes is going to be the fully synthetic group. They look nothing like the other opioids, and so because of that, there's very low risk for cross-reactivity. So if you had a patient that have a morphine allergy, and it's a true allergy, it's not just itching related to that histamine release, you may feel somewhat uncomfortable giving them a hydromorphone because it looks somewhat similar. You don't know if that patient's not going to have a reaction or not, but I'll talk about some agents that are very safe to use because they look nothing like the original parent molecules. So again, morphine allergies can be a difficulty, especially even elucidating whether it's a true allergy or not. A lot of times it's just a side effect they had. Yes, ma'am.
So if morphine converts over to Dilaudid or hydromorphone.
Hydrocodone converted.
Hydrocodone, sorry.
Yeah.
Hydrocodone. Why would you just not give this one? Is it more like addictive? Or?
No, so again, addiction is all on a scale, right? So again, you can abuse anything that's activating those opioid receptors. You can become tolerant, you can become addicted to any of those things. The issue is the dosage form that's available. So for instance, like hydrocodone is a very good oral agent. That's really the only way it comes is orally versus hydromorphone. We do have IV options that are available, right? Some of it is perceived risk of, some people hear Dilaudid, like it sounds like a boogeyman almost, right? Because if you deal with these opioids very frequently, like morphine, you give it out like water, but Dilaudid, that stuff's only for like drug seekers and for addicts. But it's not really the case. It's a good drug. It's all a matter of the dose. It's all a matter of how potent it is, right? So for instance, this one's a much more potent drug than something like morphine. As I mentioned, you can give 2 milligrams, say 2 to 5 milligrams of morphine might be equal to say half a milligram of Dilaudid, right? So again, you have to be able to keep those in mind, not just kind of change out the doses like that. So potencies are important. Everywhere you work, especially in the hospital setting, we'll have conversions because sometimes we have to convert patients from oral pain agents over to an IV agents, right? So for instance, you might imagine someone who has chronic low back pain issues, they're coming in for surgery, they need to be converted over to an IV option because they're going to be NPO. So now we have to give them, IV drips of some of their opioids. And if they're on hydrocodone at home, we don't have an option for that. So maybe switch them over to a hydromorphone drip. So again, there's lots of reasons why you may choose one or the other. But we're seeing a lot of good increased use of hydromorphone. I think people are getting more comfortable using this drug. Yep. Okay, so moving into kind of the fully synthetic sort of opioids, you have fentanyl. Fentanyl has a ton of different dosage forms. We usually see the most use for it in the OR sort of setting. We also use this in the ER as well quite a bit for kind of acute pain issues. But there's a ton of different dosage forms and routes of administration. So IV is the most common one, but we also have transdermal. Anyone ever heard of a Duragesic patch? Yeah, so here's someone who has on a chronic pain patch. It's usually going to be fentanyl, and again, it's a slow-releasing patch that will give them drug throughout a long period of time. Usually, I think Duragesics are like 3 days, I believe, but that'll give you pain control over 3 days or so. Remember that IV fentanyl can be very quick acting because it's right in your system and it's good to go. Transdermal, how long does that take to kick in? It's going to take longer, right? It can take up to 24 hours before you really start to see that really kind of kick in because you have to have that period where the drug is partitioning through the skin, right? So it's important when we're converting patients to say like from IV opioids over to the transdermal, we have to give that time to kick in. So we may leave on their drip or whatever IV opioids are on, put the patch on, and then 24 hours later we'll start to decrease the dose on the drip and then have them just be on the patch by itself eventually. So again, it's important to make sure you kind of have that crossover time there, because otherwise if you take them off of their drip and they just aren't on the patch, what do you think is going to happen? Their acute pain is going to come back, right? They're going to be in pain again, and that's not going to be good. So again, transdermal patch is good for chronic issues. There's also a lollipop that's available. I don't know who thought that was a good idea, but you think about abuse by kids, and pills already look enticing enough as it is. But oh, here's a lollipop that I'm going to suck on for a while, and but that way at least get some buccal absorption there. And we use this quite frequently intranasally as well. So if you have a kid who is does not have IV access available, and say they have an obviously deformed fracture, they're in a lot of pain, you want to give them something for it, you can just give a little intranasal fentanyl. It works very, very well. So that's another good way. We'll use that a lot in the ER setting. There's a couple other. Have I ever used the term congeners? Congeners just basically means they're kind of chemical cousins a little bit. They kind of fit in the same family. And so there's 3 congeners of fentanyl that are mainly used in the OR setting. So if you ever do your rotations, you'll probably see these being used. But there's alfentanil, sufentanil, and remifentanil. And those are 3 common ones you'll see used in the OR setting. These are good for helping to maintain that kind of general anesthesia or induce it in the first place. So because this is fully synthetic, I'm going to show you a picture of the structures here in a second. If patients have a true allergy to something like morphine or to something like hydrocodone, they are very safe to receive fentanyl because the structure is so different. It's a fully synthetic form that we made as the scientists actually made, chemists made, that looks so different that there's no cross-reactivity there. So these are very safe drugs to use. But again, the dosing is in micrograms, not milligrams. You have to keep in mind the potencies there are very different. I don't know if I took that picture out or not, but if you Google pictures of morphine versus hydrocodone, you'll see some similarities, but then if you look up fentanyl, see it looks almost nothing alike. So kind of for interest sake. Not that I'm going to have you guys reproduce that on a test or anything, but just good to kind of illustrate the point in your mind that your body can't recognize those two as being kind of similar because they look so different. Right? Okay, anyone heard of methadone before? What is methadone for? Yep, very frequently it's used for opioid addiction. So this drug is mainly working on those mu receptors. It also has a few other kind of activities. It will kind of block NMDA receptors. It also helps to inhibit reuptake of norepinephrine, serotonin. Clinically, we don't know really how much this is useful for its pain control purposes. However, it's a very long half-life, like 50 plus hours. So what do you think that might be good for someone who is addicted to opioids? Because again, with people who are on opioids, what do we want to avoid? Yeah, sure, so you want to avoid overdose, you want to avoid misuse, but when trying to get someone off of opioids, withdrawal is a big issue, right? Because again, if you go cold turkey, they're going to fail every time, right? Because they're going to have that very intense need to get those opioids back on board. However, if we can do something like methadone, where have you guys ever heard of methadone clinics? This is something where patients would kind of come into the clinic. It would be direct observed therapy, right, where someone actually watches them take the medication. They don't give them a prescription for it, right? Because otherwise they go home and maybe take all of it. Who knows? Like, because if they're addicted to these substances, who knows what they're doing? So they will come into the clinic, get Monday, Tuesday, Wednesday, Thursday, Friday. Has a very long half-life. Those levels have been building up, right? They're stacking on one another. It's a very high level by Friday, and then the clinics are closed for the weekend. And then ideally, you'd have the patients go Saturday and Sunday with no drug, but those levels are high. They kind of have a nice natural taper on itself, and they hopefully are avoiding withdrawal and won't go and try to abuse whatever opioids they liked before, right? Then I tell you what, Monday morning at the methadone clinic though is kicking. All those people are back, their levels are starting to get a little low, and they're like, I need to get my methadone, right? So that is one way to do it. There are other drugs we can use as well. We'll talk about, but methadone is kind of one of the big ones for a long time. However, we will use this occasionally for patients who have chronic pain issues. I think a lot of people are starting to move and use this for more chronic pain issues, and so that because it has a long half-life, it's good. It's kind of its own extended release preparation. So, I'll see this patient getting methadone, say Q24 hours, and they'll be like on PRN morphine for breakthrough pain or something like that. We use this a lot for our babies that have neonatal abstinence syndrome. Have I mentioned that before? You know what that is? Is it the moms abusing opioids during the pregnancy, and the kids come out? Guess what? They've been receiving all those opioids at the same time. They come out and they start withdrawing. And so it's very, very sad. If you go work in a NICU, you'll probably see a lot of neonatal abstinence syndrome babies or NAS babies. They get very cranky, very irritable. They have a hard time kind of regulating temperature. Their feeding's not very good. So you have to supplant that. You have to help to supply some extra opioids for them to help them taper off. And so we use methadone very frequently for that. So if you ever see little babies on methadone, it's basically because we're doing it for the same opioid addiction we would do for an adult patient, right? So that can be very useful to use for that. The only thing to note here is that watch out for QTC intervals. So if you had someone that overdosed on this is kind of a unique thing, especially if there's on other drugs that can prolong QT as well. But this would be one we want to get an EKG for, make sure they don't have any QT prolongation, because they would be at risk for force odds. Yeah, absolutely. Be very careful if you have someone. We have some issues where if a patient comes in and he's asking like, well, how much do you drink? They say, oh, I only have like 2 beers a night. Usually, what do you do with that number? Huh?
Triple.
Yeah, double, triple. Yeah, so usually double. All right. So if they say, oh, how much do you smoke? I was like, oh, I'm only half a pack a day. It's probably like a pack a day, right? So again, patients are more likely to lie about these sort of things. If someone comes in and they tell you their methadone dose, what do you think you do with that dose?
Divide
Yeah,
it
you
by
have
two.
it, right? Yeah, you divide it by 2 basically, right? So again, not everyone is going to do this, but you need to be careful for this. So we actually had a problem. My wife, she's a pharmacist. She was over at ORMC, and they had this program where basically pharmacy technicians do medication reconciliation in the ER. So they'll go through, they'll ask the patient what their meds are, they'll go to the pharmacist and say, here's the list, and they'll verify it, and then the admitting physician or admitting provider will go through and say, I want to keep this, 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 and DC the rest of this, right? So you have a patient, and guess what? If they're a methadone patient, you need to continue that inpatient because otherwise they'll go into withdrawal. You don't want that to happen. So this guy said, okay, I'm on this dose of methadone. It was a high dose, but not completely insane. Like because again, with tolerance, people can be on skyrocket high doses that would kill most normal people. But if you've gotten tolerant to that, then you're tolerant to it. And so the med rec tech said, okay, this looks good, and then took it to the pharmacist. Pharmacist didn't bother to verify it with anyone. He said, okay, I've seen that dose before, probably is fine. Didn't bother to call the clinic where he's getting it from, anything like that. Then the doc said, okay, it looks good to me. Go ahead and signs off on it. And then the next morning, how do you think the patient looked? Near comatose, near intubation levels here. They had to give him the antidote, which we'll talk about in a little bit, to reverse that. But the patient had lied, and no one bothered to check up on it. So you need to be careful when they're telling them if you have any history of substance abuse, anything like that. Trust but verify, I should say, is probably the less cynical way to look at it. And this is where eForce can be very useful as well. Remember that eForce program we talked about? Log into that, look it up, and that can tell you, okay, well, how much did they actually been filling for? You can call and verify and things like that. So that can be one way to kind of save your butt from a medical legal sort of standpoint. Okay. Next up, we have buprenorphine. Anyone heard of Suboxone or Subutex? This is a newer one that is being used a lot for opioid addiction as well. It's a it's a good long-acting drug, but it also is only a partial agonist. So it'll sit on those receptors and only kind of maybe give you 50% activation versus 100% like methadone would do. So the benefit of this is that you have good long-acting effect. It'll have a nice natural taper. You can taper down the dose for your patients. And the other big thing is it binds very tightly to those receptors. So if someone went and did methadone on top of this, or they did morphine on top of this, or heroin, you wouldn't get as much of an effect because the buprenorphine is kind of sitting on there and only kind of partially tickling the receptors. The heroin can't come along and knock it off, essentially, right? You can take a big enough dose of heroin to eventually knock it off, but it would take a lot more than usual. And so that's one of the reasons why we're starting to use this. We will see that it is also, a lot of times, compounded with the drug naloxone. I'll talk about this more in detail in a second, but what is naloxone? It's Narcan. What does it do? Yeah, it reverses opioids, and basically naloxone is not absorbed orally. So if I take buprenorphine orally and it has naloxone in it, it doesn't do anything. However, if I want to abuse buprenorphine and I want to inject this product, if it has naloxone in there, then it would kick in and basically is trying to deter abuse. So if you see that combination, you're like, well, that doesn't make sense. Why do you put an opioid with a reversal agent? Check to see what the kinetics are. If it doesn't get absorbed orally, then it would make sense at that point, right? Okay, so in general, basically you should be trying to focus on, looking at their pain intensity, look at their coexisting conditions, economic factors, because a lot of these products can be, brand name still, it can be very expensive in a lot of cases. But basically, the main goal is to use a long-acting formulation to help control that basal pain for those chronic pain patients, plus having a short-acting opioid therapy on top of that, right, for the acute breakthrough pain. Now, if it's someone who just had, like, say, a broken arm, do they need a long-acting formulation with an acute formulation on top of that? No, that's an acute issue. It's going to be something that's temporary. However, if it's, they had an injury and they had this chronic low back pain, that might be someone who's going to be better off at getting a basal kind of drug and then getting a breakthrough drug on top of that. Think about cancer patients who are, especially palliative care patients who are going to be in a huge amount of pain. Those are chronic pains. They're not going to be acute. They need to be on both formulations. If I stub my toe and someone's really nice and gave me some opioids, I only need an acute sort of drug, right? I don't need long-acting formulations, okay? Okay, so generally try to go oral if we can, but for more chronic pain patients, we will use a transdermal fentanyl. So that is one thing you may see patients on. One thing to note with the transdermal fentanyl, if you ever work with the formulation, a good patient education point is to not apply heat to the patch. So again, if you think about it, like, if your back's hurting, what's something you might try to use as a non-pharmacologic aid? You might use a heating pad, right? The problem with that is if you apply a heating pad to that patch, it will increase the release of the drug, and there's been deaths associated with that. Or people, sometimes you want to get in the jacuzzi to help kind of relax some of those muscles. People have died in the pool because of that, because they had that heat, increasing the release of drug, got all in their system at once, and then boom, respiratory depression, they're dead. So be careful with that. It's a good patient education point to remember. So, switching over to IV agents, if you don't have an IV available, but you need something a little bit better than oral, a little bit quicker, intranasal fentanyl is a really good option to go with that. And in general, don't show your whole hand. Don't be the magician that does the cuts of the assistant in half at the very beginning. Like, you need to make a rabbit disappear, something kind of more benign. Start low, go slow. You can always give more opioids, but you can't really take them back, right? Okay, so looking at adverse effects, most common ones you're going to run into clinically are going to be constipation is huge, right? So a ton of constipation. It's very, very important that you help to manage this appropriately, because this is never going to go away. They're always going to have this issue. And so normally what the method we use to treat this is with the push and mush method, or mush and push method. So when I say that, what do you think it means? Because we covered GI already, so you can think back to your laxatives. So what are some different types of laxatives that we had?
Powder forms or the...
Yeah, so it's like an osmotic laxative to help drew some water. So we are starting to use those a little more often, especially since Miralax is over the counter now. Remember we had stimulant laxatives? That's a push, right? It's going to directly stimulate peristalsis in the GI tract. So a lot of things like Senna that we use in order to help kind of push that through, or bisacodyl. The other thing is the mush. Those are going to be stool softeners, okay? So those are going to be things like, trying to think, Docusate that are going to help to emulsify the stool, make it a little bit easier to pass. So you need to have kind of two regimens or two different drugs from different categories to help with that. Otherwise, they're going to get very stopped up, and it can lead to abdominal pain, which may lead them to try to self-medicate, and just no good. So again, never underestimate the value of a good poop. My wife, when dealing with some of these palliative care patients, end of life, they, you try to get their pain under control, and you're giving them all these opioids, and you're like, what's going on? The heart rate's still up, the blood pressure's still up, and you realize, oh, he probably hasn't had a good, bowel movement in a while, and you give him a little clean out, and all of a sudden, pain is under control, and everything's right in the world again, right? So again, really think about the constipation aspect of this. Yes.
They say that the ones that stimulate motility to not do it long term, but what about these patients who are on long term?
It's one of those things where it's like, yeah, you're gonna have to do it. Like, you're just gonna have to be aware of it, and if they ever come off of their pain meds, like, then you can try to wean them off of the stimulant. But it's like, it's one of those things where, like, you really need something more than just like a Miralax by itself or something. You need like kind of a dual mechanism there to try to get that stuff out. Sedation is going to be another big one. So again, think respiratory, think CNS depression with these drugs. And I mentioned the histamine release, but mostly going to be with morphine. See this with codeine. Switch over to like a hydromorphone or hydrocodone. You'll see a lot less of that. Now, again, frequently, or less frequently, I should say, some patients are going to have, kind of ultramental status, delirium associated with these drugs. Just depends, just because they have it with one agent doesn't mean they'll have it with all of them, so you can try switching out. And then watch out for that respiratory depression. Low risk with normal dosing, but, just remember that as they try to self-medicate, there's a higher risk for that. Especially when you start to mix with other CNS depressants, like benzodiazepines, or you mix with alcohol, your risk is just going to go up for those respiratory depression there. And again, think about the risk of abuse. Think about diversion. When I say diversion, what do you think that means? No. Yeah, so this could be a case where, and this can go for healthcare providers too. So again, healthcare providers are not immune to the allure of opioids. Anesthesia is a big hotbed for drug abuse and misuse. And so again, we can have diversion where if you notice, we do this. Every hospital usually has like a committee that will be looking at opioid use within the hospital because they're looking for diversion, right? So if you notice, like, man, Nurse Nancy, she's always the one going to go to the Pyxis. She's always the one drawing morphine every single time, like, that's kind of weird. She's using more than 2 standard deviations more morphine than anyone else. That's kind of odd. These are things you look for. Or like, man, someone always has a discrepancy on their count with this one particular nurse or this one particular provider. These are things where you kind of have to start to look at patterns, and then once you kind of assume something, then you can do things like drug tests and follow up and whatnot. But that is a risk. Either the healthcare providers using it themselves, or they are potentially selling it, things like that. So you have to be careful with those kind of diversion cases. So there's been several people who've had licenses taken away or lost their job due to these diversion concerns. So be very careful with that. Okay, so in general, again, titrate gradually, as I mentioned, start low and go slow. Try to determine the cause of symptoms. So again, if they're having increased abdominal pains, is it related back to constipation, or is there something else going on? You can always change the route. Look at the regimen. There's always, some people respond well to one type of drug versus others. Some people hate hydrocodone. Some people do really well with it. So again, you just have to try within the same kind of opioid family to see kind of what they're going to respond better to. As I mentioned, that mush and push is very important to keep in mind with that. Again, you can try to recommend good fiber and fluid intake. That will help, but it's not going to really fix the problem. And again, a lot of times we'll use a combination drug like Senecot S, which is Senna, which is our stimulant plus DocuSay, which is our stool softener, the emulsifier there. So that can be very useful. And then nowadays we're using a lot more Miralax, things like that, to help with kind of an osmotic laxative sort of effect, mainly because the availability of Miralax is a lot higher now because it's over the counter. Okay, so from an antagonist standpoint, we have naloxone. This is going to be the primary one. Naloxone, as I mentioned, is only available it does not get us orally. However, there's lots of other routes we can use it. So we can use it intravenously. Most common way, we use it intramuscularly, intranasally. I've seen naloxone being used intranasally nowadays for patients who don't have IV access. And then there's even, you guys ever heard of this Evzio? It's kind of cool. It's like kind of a mixture between like an EpiPen and there's AEDs. You ever worked with an AED before? The guy like when you get BLS and talks to you and kind of walks you through the whole process. This will do the same thing. You basically will pull a tab and it'll say, okay, hold against outer thigh, and you hold it there, and it's like push down, you push it, and then say hold it for 1, 2, 3. You know, go through the whole process, which is good because a person who's overdosed on opioids, are they going to be giving themselves this medication? No, they're going to be passed out. They can't really do that. It'll be other people who are around them who may be prescribing or maybe administering that. So it's either a friend or a family member or something like that, or potentially, you know, if it's the police are showing up first, or if it's EMS. And actually, if you look at, I was doing a presentation on this recently on intranasal naloxone administration, but basically, Orange County Sheriff, they went ahead and gave doses of naloxone to all of their deputies because in 30 to 40% of the time, they're the first people to show up to one of these calls. So if they can get there that much sooner than EMS and provide a dose of naloxone, you might be able to save a life in those cases. And so that's a big deal we're starting to see nowadays. There is some concern because there's actually it's interesting, there's a law now in Florida where it says that you can get a blanket prescription from a physician for naloxone, either intranasally or for one of these auto injectors. So that way you can say, okay, well, you might be a high risk for opioid abuse. I'm going to give you a prescription for this. So that way your family member can get administered to you if they find you in the state or something like that. So some people are worried about, you know, sort of enabling use. My big concern is if these kind of programs, and you'll find other programs that are kind of giving out doses, is that if a family, you know, a friend or family member like finds someone like this and they give them a dose of naloxone, and they fix the kind of the immediate issue, the thing you're going to find is that naloxone does not work very long. So only about 20 to 30 minutes does it stick around. Once that's over, if that drug is still around, guess what? They're going to go right back down again. Okay, so this is one of the big concerns is that people will administer this in the field and not call 911. Because otherwise the patient's probably going to go back down again based on the amount of drug in their system. So now, not a lot of side effects from this drug, but what do you think might be one side effect? It's going to go in and kick all those opioids off the receptor. Withdrawal, right? So if you ever got a chance to see a Narcan reversal, it is very stark. Anyone ever seen one before? What's it look like?
They're like comatose and then they just like rise from the dead.
Yeah, essentially, yeah.
That's crazy.
Yeah, it's like The Exorcist. I think is a good description for it. So basically, when you give them naloxone, if you give them too much, they will go from completely comatose, needing to be intubated, to fully awake, totally aware of what's going on. Usually pretty mad, especially if they're abusing this stuff for you know, for euphoria purposes. And they will their whole GI tract wakes up at the same time, so they'll have lots of nausea, vomiting. They'll have diarrhea associated with it. It can be very, very bad, right? And your nurses are going to hate you if you administer too much of it. So the goal is you want to give them just enough to kind of help to start to reverse the process and just to have them breathing. You know, a lot of times you don't want them awake. They're probably less pleasant awake than they are asleep. So just have them breathing. And so one of the big things you can tell if you're giving enough is they start to yawn. Because basically what happens with opioids is they kind of blunt the brain's response to CO2. Because again, normally when your brain kind of detects all that CO2, it stimulates respiratory drive. That is blunted with opioids. So if I give them just enough naloxone, that'll start to wake up that respiratory center. They will start to get that feeling, hey, there's too much CO2 around. They'll start to yawn and start to breathe more to blow it off. So that's one of the things you can see. If you see that, you gave enough. And make sure you're monitoring the respiratory rate. You can do things like monitor end-tidal CO2. Those are all very useful. But don't give too much. However, you know, if it's, you know, in the field or something like that, you know, again, I'd rather have them awake and screaming than dead. So you can kind of take your pick there. Anywho, there's a few agents that are available for use in the postoperative setting. These are peripherally acting opioid antagonists that basically are good for opioid-induced constipation. So you see this used in the postoperative setting to try to wake up the guts after they receive like a lot of opioids for general anesthesia. And so basically they don't cross the blood-brain barrier, so they don't really deal with any of those opioid effects in the CNS. However, they work on the GI tract to wake things up again. So I have things like alvimipam, methyl naltrexone, and naloxegol. Those are the three main ones we're going to use as a peripheral acting drug. It's not going to wake anyone up. That's a good thing because we don't want to necessarily reverse those pain analgesic effects. However, we'll wake up the GI tract and hopefully get them defecating again. Okay, so a couple other agents we have available that can help us with this. So these are more for neuropathic pain issues we're going to see here. We have things like anticonvulsants. We've covered these already. We'll talk about lidocaine, transdermal, and then some of our tricyclic antidepressants, which again we've covered already. Again, you're going to find that there's a lot of variable response with these, and not one drug is going to be perfect for neuropathic pain as compared to anything else. Again, opioids act like opioids no matter what. However, there's a lot of variability with these neuropathic pain issues. Now, again, opioids could work for neuropathic pain, but we like to hold off on that and only use those if they're kind of refractory to everything else. So these are good ones to use. You have a diabetic neuropathy, if you have herpetic neuralgias, anything neuropathic-wise, this is going to be a good drug for that. So some of them we'll talk about in some detail. Again, we'll look at some of the antiepileptics, local anesthetics. We'll talk about marijuana a little bit as well, but there's lots of different options that are out here for this, right? So we'll go into more detail on these. Yes?
Is Tramadol like narcotic-like, but it's not a narcotic or something like that?
We'll talk about that in just a moment. But yes, you're right. Okay, so the antiepileptics, you're going to find that a couple of these we've already talked about can be used. Now, the most common ones that I see, especially for things like fibromyalgia, are going to be things like gabapentin and pregabalin, like Lyrica, Neurontin. Those get used very, very frequently because, again, they're pretty mild from a side effect standpoint, a little bit of sedation, but they can be somewhat effective. So you'll see that very frequently. But other drugs like carbamazepine, lamotrigine have been used as well. So just know you may see a wide variety of antiepileptics. Doesn't mean someone has a seizure disorder just because they're on one. Could be because of bipolar disorder, as we saw, or it could be one of these neuropathic pain conditions, right? But again, sedation and mental clouding are going to be the biggest side effects to watch out for with these. Tricyclic antidepressants were kind of the gold standard for a good long time, but nowadays we're switching over to agents that have less side effects. So for instance, they're working by blocking reuptake of norepinephrine and serotonin. What other drugs do that? SNRIs, right? So again, the SNRIs are used very frequently. So you see like a Cymbalta, which is duloxetine, or say like a venlafaxine, which is Effexor. Those are starting to be used as well because they lack a lot of side effects, as we know from our talk on behavioral stuff, because these drugs have a lot of anticholinergic effects, a lot of different side effects associated with them. So these were used for a good long time. It's starting to kind of wane a little bit in lieu of things like the SNRI. So just know that you might see this being used for this purpose as well. The local anesthetics are very good because they are kind of helping to blunt the transmission of the pain signal from the site of pain to the CNS by blocking those sodium channels. Remember when we talked about lidocaine being used as an antiarrhythmic? Doing the same thing for the nerves as it is for the heart by blocking the sodium channels. And so there's a couple of different options we have available to us. We have things like Emla cream, which is a mixture of lidocaine and prilocaine. We'll oftentimes use this topically for things like needle stick analgesia, right? So especially in a kid's standpoint, kids are very needle phobic. They're very worried about pain. So we can apply a little bit of this to the site where we want to get an IV and numb up the site and hopefully deal with some of that pain. Or if they're having like, getting a laceration repair or something like that, we'll inject lidocaine into the site, try to numb it up. That way we can do our thing. And this is very opioid sparing because if the patient never experiences the pain in the first place because the nerves are deadened, then you don't have to worry about it, right? So you don't have to worry about treating they never experience that pain in the first place. We also have things like patches for lidocaines. I remember for a lidoderm patch. Those can be applied kind of locally to wherever the site of pain is. Can be very useful for that. And then we use this very frequently from an epidural standpoint or for local and regional blocks. When I say local or regional blocks, what do you think that means?
Nerve block?
Yeah, it's like a nerve block, but we're using it at the site where the pain is. So imagine if you have, say, a hip replacement. What if we can just deaden those nerves right there at the hip and not have all those pain signals traveling up the CNS? You can avoid using a lot of opioids because of that, because the patient never gets those pain signals. And so we will do that in a lot of orthopedic procedures where we'll apply local pain blocks, so things like bupivacaine or things like ropivacaine. We'll cover this more in a surgery section a little bit later, but just know that these are blocking sodium channels. These are very good for kind of localized kind of effects. So I call these local anesthetics. Okay, they're not going to be good for global effects. They're good for localized effects. Also, like in epidurals, we mentioned like during pregnancy or during labor, I should say, we'll apply some of these anesthetics in the spinal column and as an epidural in order to get kind of localized anesthesia from, say, like the waist down, right, for someone who's giving birth. So very good agents, very good at sparing opioids in the surgical setting. We have several skeletal muscle relaxants. These are actually working on, if you guys remember the benzodiazepines and them working on the GABA A receptor, these are actually working on the GABA B receptor. And these tend to be have similar side effects to some of those benzodiazepines, mainly the CNS depressing sort of effects. However, they can be good at kind of relaxing some of these muscles, especially if the patient's having issues where they're having kind of this pain, spasm pain sort of thing. The cycle that happens where basically they will experience pain in the muscle, they'll spasm up because of that, and then that causes more pain in the tissue. And so this is good to help kind of relax that a little bit to try to interrupt that signal there. So things like baclofen, cyclobenzaprine, metaxalone, methocarbamol, and tizanidine. Those are the most common ones you're going to run into. And again, think about someone who's got chronic pain issues. They might be on a baclofen plus an opioid plus, say something like another sedating med, like, for sleep, because the pain's keeping them awake. These drugs can kind of stack up on you after a while. And so you kind of mix all these sedative drugs together, you can run into some issues. So it's very important to make sure you're going slow with these to not kind of overwhelm the patient, especially if they need to go to work or drive or anything like that, right? We haven't talked about osteoarthritis yet, have we? No, I think that's what we're going to next. But we'll talk about capsaicin a little bit then. Anyone know where you find capsaicin?
It's a cream, right?
It's a cream you order normally. Where else can you find it?
Jalapeno.
Jalapeno, yeah, peppers. So you find it in peppers. This is what gives peppers their spiciness. And we're kind of doing the same thing for these nerves here. We're giving capsaicin locally. This is good for kind of localized inflammation, things like that, because basically this helps to cause those nerves to release substance P. Substance P is very important for pain transmission, and basically by causing these nerves to release all that substance P, they kind of run out of it, and they are less likely to transmit those pain signals. So it can be very good for things like osteoarthritis, for kind of localized pain issues. However, you have to use it very consistently, and when you apply it at first, like, how do you think it feels? It feels hot. Yeah, it does not feel good. Like, everyone ever like cut a pepper up and have it, start to burn their hands or accidentally, or what I instinctively do whenever I cut jalapenos is my eye automatically itches and I got to rub it, right? Right. So be very careful with that, because again, this will act the same way. If you get it in your eyes, any kind of mucous membranes, it's going to burn like heck. It's going to be very uncomfortable for the patient, and they need to really make sure they're washing their hands very well. Again, this is very it's a lipophilic substance. So has anyone ever anyone know what to do if you have, like, it's like a really hot pepper you ate, or if you get something like in your eye? Yeah, milk. Why milk?
Something it works.
No. So the fat, yeah, absolutely. So we use it for the fat. And actually, I remember one time I had a call at the Poison Center. We had a girl who she was cutting up peppers, and she, for whatever reason, like, it was just like severely burning her skin. She had like a break in the skin or something like that. And she's like, "What do I do?" And I was like, "All right, what do you got around the house? Do you have any like olive oil? Do you have any like mayonnaise? Do you have any like milk?" She's like, "Oh, yeah, I got some milk." And I was like, "Is it full fat milk? Because the skim stuff's not going to work." She's like, "Yeah, it's full fat milk." I said, "All right, pour it all over your hand." She's like, "What the heck is that going to do?" I'm like, "Just do it." And call her back 10 minutes later. And she's like, "It worked. It was amazing," because the capsaicin will partition over into the fat layer, and then it can be washed away. And so that's why it's good for your mouth, good for mucous membranes, very good at helping with that. So anyway, big thing I can recommend though is that they use gloves when they do it. That way they can just take the gloves off and they don't have to worry about contamination, right? But they need to use it consistently. If they use it sporadically, that substance P will come back to those nerves, and then it'll kind of start to fire off all over again. So very good, very useful if they're going to be consistent with it. Otherwise, a lot of people will kind of fail therapy with it because they just don't want to stick around with it. Anyone know what scale you use to measure the spiciness of food? Close as an S. The Scoville, yeah, Scoville scale. There's I guess a scientist named Scoville who designed this. So you see those like Carolina Reapers or whatever. They have like a gazillion Scovilles, hottest pepper ever, things like that. So it's kind of interesting. But anywho, next is Tramadol. So this one's kind of like a cousin to the opioids. It's a partial agonist. It's kind of a wimpy from the standpoint. It's not going to be as good as like a morphine or a hydrocodone, but it's pretty okay at some more kind of mild to moderate pain. Biggest thing to note with this is it helps to block reuptake of norepinephrine and serotonin, so it's very good at helping to treat neuropathic pain. So you'll see it uses it for that occasionally. And for a while, it was a non-controlled substance. So that means you can get it without any kind of restrictions on it. Anyone could prescribe it. It was not a problem. However, we did see that there was some abuse associated with it. So because of that, again, a few bad apples have to ruin it for everybody. Now it's a C4. Now it has the same regulations as any other C3 through C5. So there's some problems with that. But just know it can cause a similar, constipation, sedation. It won't be as severe as with like an opioid, kind of full opioid, but can still do that. But just know that the other big risk you have to watch out for is going to be seizures, because it has that norepinephrine effect there. So again, in overdose, we run into that problem quite frequently. And it does have a formulation with some acetaminophen. So you see that Ultraset, that's another combination. And what did I say was the big thing with acetaminophen? The liver. Yeah, so how do I assess for a patient's acetaminophen intake? Well, look at all sources, right? So make sure you're asking about, are you taking acetaminophen by itself? Are you taking hydrocodone? Are you taking Ultraset? Are you taking all these things? Because again, patients will sometimes squirrel away medication for self-medication later on, and you may find they're getting way more acetaminophen than what they're bargaining for. So make sure you ask the question, because otherwise you will have to do things like your LFTs and PTINRs and all that to make sure they're not damaging anything. Okay, so any questions on that? All right, let's take 10 minutes. We'll come back and then start off with our rheumatology.